for joining us today for this webinar on state-specific Medicaid coding and billing updates for Arkansas, Louisiana, and Mississippi. I'm Kate Stenyum, and I'm a program manager with the Delta Region Community Health Systems Development Program. The Delta program is providing this webinar today. As a reminder, the Delta program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. As a reminder, and as some of you may have heard, today's webinar will be recorded and it will be posted to our website. Cineva Hackman will send out a link to the recording, and the presentation slides will be included in that, and they'll also be posted to our website as a resource for all of you. If you have a question or a comment during the presentation, it is *2 to unmute your line, or you can utilize that chat box on the left-hand side. So even if you have a question that comes up as Marla's going through the presentation, I would encourage you to put it in that chat box, and then we can, Marla will go through and answer those at the end of the presentation, just so it doesn't you don't lose your chain of thought or lose the question that you had. Use that chat box at any time to put your question in there. Right now, before we go ahead and get started, please take a minute to find that chat box on the left-hand side of your screen, and if you could type in your name, your title, and your organization, that's really helpful for our presenters to get a good feel of the audience on the webinar today. So again, if you see that chat box on the left-hand of your screen, take just a second to type in your name, your title, and your organization. So the state Medicaid programs have issued specific guidance for rural health clinic sites, as part of this COVID-19 public health emergency. And our BKD consultant, Marla Dunn, will outline the updated billing and coding instructions for the state Medicaid program on today's webinar. Again, this webinar is tailored for specific state Medicaid programs in Arkansas, Louisiana, and Mississippi. We had a webinar yesterday that focused on Illinois, Missouri, Kentucky, and Tennessee. I also want to put a note out there, if you missed the session that Marla did on Medicare telehealth billing and coding guidance, that webinar was recorded and it is available on our website. So Marla is with BKD, and BKD has been closely monitoring the updates from CMS and state Medicaid and have received many questions regarding the telemedicine changes and how that's going to impact our rural facilities right now and into the future. We know this has been ongoing and changing all the time, so I just want to say a huge thank you to Marla and the team at BKD for giving us the most current and up-to-date information available. One more thing too before we get started, I want to take a moment to let everybody know that as part of the Delta program, BKD is developing an 8-state specific resource tool which will outline the Medicare and state Medicaid telehealth and virtual communication billing and coding guidelines. So these resources are going to have the specific Medicare and state Medicaid telehealth and virtual communication billing guidelines, and it's going to include links to the Medicare COVID-19 billing source documents, links to the state Medicaid COVID-19 billing source documents, the CPT and HCPCS codes, the ICD-10-CM diagnosis codes, documentation requirements, modifiers, CMS 1500 claim place of service codes, UB04 claim revenue codes, the eligible providers, and the eligible telehealth or virtual communication services. So these tools are in the process of being finalized right now, and Cineva Hackman will be sending them out to all of our Delta organizations later this week. So be on the lookout for those because it'll be a very helpful resource. So with that being said, I'm going to now introduce our expert speaker from BKD, who will provide insight and detail that you need to be aware of. And while I'm doing this brief introduction, I'm going to ask Cineva to pull up some polling questions. So if everybody could take a minute and look through those polling questions and fill those out while I'm doing the introduction, that would be most helpful. So Marla Dunn is a managing consultant with BKD, and she has more than 20 years of experience in the healthcare industry. Marla provides reimbursement and compliance audit services as well as education to physician clinics, provider-based clinics, rural health clinics, federally qualified health centers, and outpatient behavioral health providers. Marla has CPC and CRC certification through AAPC and CCSP certification through AHIMA. And she is also an AHIMA-approved ICD-10 CM trainer. That is all such a tongue twister, and I think I'm getting a little bit better with saying it as the more webinars that we do. But with that, I'm going to turn things over to Marla to get started.
Thank you, Kate, very much. I know when I hear my bio, I sometimes go, oh my goodness, I'm like really old because I've been in the business for so long. Oh my goodness. Well, thank you, everyone. I appreciate, again, the opportunity to work with the Delta program and provide some education for you on this ever-changing telemedicine world that we're currently in due to the public health emergency. And I know that we, as Kate had outlined, have covered the primary Medicare side, particularly in focus with our rural health clinics, because that has been a moving target, really, from a Medicare perspective, and we are still waiting on a fourth revision of guidelines as far as we're aware that Medicare is working on. So we're waiting for that with anticipation. But the webinar that we hosted yesterday was specific to state Medicaid, as well as the webinar we have today. We are really going to focus on what the state Medicaid programs want in relation to telehealth. And as I shared with the group yesterday, your state Medicaid programs really have been ahead of the curve to a great degree in advance of this COVID emergency, particularly from the rural health clinic side. The state Medicaid plans have always included the RHCs as well as FQHCs as a distance site provider for telehealth, which included multiple specialties as well as core providers on both the medical and behavioral health side, to include additions for substance abuse services as well. And while we're not going to dig into the weeds of all the distinct specialty services, we just want to make sure that everyone is tied to their state Medicaid resources, that they are up on the service codes that are eligible for telehealth, as well as the providers. And we'll step through some of those high points through the presentation today. But I will say that, some of our questions that we asked prior to the training, is Medicaid a direct mirror of what CMS has issued as far as waivers and guidance for billing as part of this public health emergency? And it's kind of a yes and no answer. They have not mirrored 100% of everything. They often will adjust those waivers to meet the state requirements. There are a lot of the waivers that they have taken, like the waiver opportunities for coinsurance and for really expanding the access to medical care to include telehealth and virtual communication. So I would say that the state is using CMS's instruction as guidance and then adjusting their guidelines accordingly within the state criteria. So we're going to walk through some of the billing guidelines that the states have currently in place. We're going to start with telehealth and just walk through really the three categories that still exist for telehealth, that umbrella really of telehealth, or that definition of telehealth or telemedicine. You'll see that terminology used interchangeably, and really it's kind of an umbrella term. But the true telehealth, which is our audio-visual, where that patient has access to audiovisual software or applications that are a real-time communication with the provider. And that can involve either synchronous, which most of the payers, particularly state Medicaid, we've noticed that they're very firm on that it needs to be audio-visual. Some have opened up that phone-only opportunity, but they want it to be real-time regardless. So state Medicaid really does not encourage billing or coverage really for the asynchronous, which is really a store and forward mechanism of telehealth, where the patient may be sending a document or an image, a photograph to the provider to review or assess before then contacting the patient for communication. Medicaid really is very distinct that they want that to be a real-time, two-way, synchronous type of audiovisual or phone-only type of conversation. Really, when we're looking at telemedicine or telehealth, that audio-visual or phone only, that's really concentrated on those true evaluation and management services. Basically a service, whether medical or behavioral health, that you would be rendering if the patient was in the clinic or in the hospital outpatient department and rendered in person. That is really the purpose of telehealth. It's a replacement for that in-person visit. And so that kind of narrows our thought process when we're trying to decide, is this an e-check or is this a true telehealth service? It really depends on the work that was performed. And if it was really a true evaluation management service or a therapy service that was rendered over that audio-visual as a replacement for having that patient come into the clinic, that it really falls under that telemedicine. The next category is e-checks. This is where the criteria is to a patient-initiated brief phone call, 5 to 10 minutes in length, and we really refer to this as a triage call. There are a lot of guidelines around these e-checks. The basic rule of thumb with both the e-checks and the digital or the electronic portal visits are that you bill once every 7 days. There is no duplication of that. And some of your payers, and the guidelines, of course, may differ from payer to payer, but really Medicare as well as state Medicaid has been pretty clear that they don't expect to see that service billed more than once every 7 days. There are scenarios where you may have multiple conversations with that patient, or that patient may call in to have signs or symptoms or conditions or questions answered or triaged during that 7-day period, and you would basically need to accumulate that time to determine what you're billing, depending on whether you're doing fee-for-service, Medicaid billing, or whether that's going to be rolling into the G0071 on the Medicare side for a rural health clinic, for example. So the e-check, again, is just that brief patient-initiated call to triage any signs, symptoms, or conditions that the patient has. Basically, the provider is assessing what the patient is telling them and directing them on what to do next. Especially from a COVID perspective, this falls to, do we need to quarantine for 14 days? Do we need to go to a testing site to be tested? Do we need to physically come into a clinic or an emergency room, or is this a scenario where you need to be admitted and would present to the hospital? Those next steps are what are determined, but it is not for a full evaluation and management service. The other thing that Medicare particularly cautions on is that this is not just to bill for phone calls that your providers may be making to patients in follow-up. They may be checking on the patient, or they may be confirming that a prescription's been sent. They may be calling just to let them know that lab results are okay, things like that. If those are just normal phone calls and not a true e-check or a true evaluation and management service, then those are still not truly billable phone calls. And Medicare has made a point of that differentiation on some of their Q&A calls over the last many weeks. Then we have the category of digital or electronic portal visits, and this is when organizations have an electronic internet portal set up. Often patients will get into that system to look at their notes. They are often answering surveys, but it also usually contains some type of portal to communicate with their provider or maybe nursing staff in some circumstances. For this scenario, it's visits with the provider, physicians or non-physician practitioners or behavioral health providers, where there is usually an email or instant message type of communication back and forth between the patient and the provider through that portal. There's no audio, there's no visual. It's just basically emails back and forth. Those are also very brief. You have to have at least 5 minutes of time over that 7-day window. And again, sometimes the payers will bundle the coding guidelines similarly for both the e-check and the portal visit. So those are the 3 categories that we still have. And I know some providers that we talk to over the last several weeks are still a bit confused, especially with the phone services, given that Medicare and most of the other payers have opened up those telehealth visits to a phone-only service with a caveat that is for a patient who does not have access to audiovisual technology. Last night on the CMS call, there was some questions about phone services, and the CMS director or staff who was answering questions said that, some practices just provide tablets or provide some type of application to their patients so that they're able to open up those audiovisual communications more easily. And that's something, obviously, the healthcare industry is looking at now and going forward, just to make sure that their patients do have access. But we do understand in some states, some of these patients are in areas where there is no phone access other than landlines. And so it is very difficult to open up an audiovisual or electronic internet connection with those particular areas of the state. So we do have some revision dates. One thing we will say about state Medicaid is that they usually do not fall to the same day. Medicare is very distinct always on their effective dates for particular guidance, where Medicaid drives their guidelines often on when we have issued that guidance or when that letter was distributed to the providers. And so the deadlines or the effective dates that we have as part of the telehealth billing guidelines between states are often different. So I've provided you with what Arkansas Medicaid's effective date is, and that would be for dates of service on or after March 18th. In some of the guidance that I was reviewing last night, there are some areas that they don't retroactively put it back to that date, but this is the standing effective date for telehealth billing and virtual communication. Louisiana, it's March 12th, and for Mississippi, it's March 20th. And for all states, these guidelines that are in place, as well as any guidelines that are revised or changed going forward, will be in effect until the end of the public health emergency, which would be a national declaration. We do have the two components of our audiovisual telehealth, which is what we'll talk about first. Again, that is our audiovisual, as well as now that phone-only evaluation and management, maybe a behavioral health service like therapy, that service that would have been rendered if the patient was in front of them. And we have the two categories, the originating site, which is basically the facility component of that service, or defined as where your patient is located. And there are some waivers that were issued by CMS that were mapped over to most of the other payers to include state Medicaid. And one of that is that there's no restrictions now on the originating site. So the patient can physically present really anywhere, whether it's an urban area, a metro area, a rural area, just any healthcare entity they are able to present to, and also opened it up to allow them to be at home when that communication takes place. So that is specific to the public health emergency. Medicaid does also go on to just define a little bit more that patients can be located in a temporary location. And this is where often we'll have an out-of-state scenario where the provider actually is in Arkansas or Louisiana or Mississippi, but the patient may be elsewhere. College students have been a good example of that, where most of the colleges closed early and went to remote, so a lot of those kids went home, and their homes are in other states where they are still obtaining or requesting medical services through their prior maybe primary care provider or behavioral health provider back at school in that state. So Medicare and Medicaid both have been very open to, that relationship just needs to be established to begin with, but that care can be rendered even if the patient is now out of state, as long as the provider who is rendering that service is, licensed, et cetera. And we'll walk through some of those caveats in a few slides. Medicaid specifically went an extra step and removed some of the prior authorization requirements that were previously in place for some of the telehealth services. This is more on the behavioral health side, I would say, where there usually is a layer of pre-certs or pre-auths that have to be in place before services are rendered. And state Medicaid plans pretty much across the board for all states opened up those restrictions during the public health emergency. We would recommend that you do keep in touch with your Medicaid plan, make sure your billing office or your front end desk or whoever is scheduling for patients make sure that they are well aware of what those allowances are now with pre-auths and pre-certifications, particularly on the behavioral health side. to make sure that that's all in place before those telehealth services are rendered. This is actually the facility component of this telehealth service. So you're familiar perhaps with the HCPCS code Q3014. This is really the universal code that reflects that originating site or that facility site fee. And now, during the emergency, this is really going to be billed when a healthcare site actually has the patient physically located there at their site. And it is Q3014 regardless of payer, recognized by our state Medicaid plans. So for example, if that patient presents to a fee-for-service clinic, that would be a 1500 claim form. The place of service would be for the type of clinic, 11, for example, for a freestanding physician office. If that patient is presented to your rural health clinics, you would be billing that Q3014 on the UB04, the 711 or your usual and customary visit type of bill, and would report under revenue code 780, which has been designated specifically for this code. And you are paid fee schedule by the state Medicaid programs for that facility component. And again, that's when the patient presents to the rural health clinic, and then you are facilitating that communication with a provider outside of your system or your clinic. That provider is elsewhere. If the patient presents to the hospital, then the hospital would generate an outpatient UB04, usually a 1-2X type of bill. They also have to go through an extra step of putting a type of service 9 indicated on the UB04, and then the revenue code that would tie to the site where that patient has presented, whether it's 510 for a clinic or whether it is another revenue code for emergency room, for example, depending on where that patient presented. These services are universally paid under fee schedule, and really we're seeing a variation of prices or fee rates between the state plans, and we're really seeing anywhere from $15 to up to $25, depending on the state. So when your reimbursement team is receiving those paid claims or those remits, they may see differences in dollar amounts, where from Medicare, for example, and some of your other commercials and MCOs, you'll see one flat rate that is paid. Medicaid, it will depend on the state's fee schedule. Now, there is a scenario that has been opened up through the healthcare emergency for the telehealth service when the patient is at home and has not physically presented at a healthcare entity. So the service may still be rendered, but the reminder is that that Q3014 is not billed, particularly by an RHC or clinic if that patient is at home. There has been some movement on the hospital side when you have a provider-based clinic that is not RHC, where there may be a split billing or a facility component billing, usually for a service that would have been rendered in the provider-based clinic, for example. And they obviously have had conversations with Medicare, and state Medicaid also has some allowances and some language in their guidance as well about what might be billed. So when the hospital setting is your scenario, and the patient really is receiving that distant site or that professional telehealth service from a provider in your provider-based non-RHC clinic, then a lot of the state plans will allow the hospital to bill that Q3014 to show that facility component, because the hospital is still absorbing some overhead to include the nursing time, because a lot of the nurses will get on the line or the connection before the physician or the non-physician practitioner gets on the line to do basically that rooming work that they would have done in person, taking vital signs subjectively, asking those questions of the patient, getting that initial history, as well as getting the consents. All of those types of ancillary staff work is still being done, as well as potentially equipment, et cetera, that the hospital has incurred for that technology. So a lot of the state plans also will allow that, and again, that's for hospital billing and would not be billed for an RHC regardless if that RHC is provider-based. Differences in payment methodology. Now, the example that you see on your claim form is one that I pulled from Missouri Medicaid for the presentation yesterday. I did not see any billing examples with any of the other state Medicaid plans, but I wanted to provide this to you in case you are in conversations with your state Medicaid program as to how they want those hospital claims to come through. Obviously, you'd have the distance site service that would still go on your 1500 claim to state Medicaid. You'd have the service code, usually place of service 02, which is universal for all of the state Medicaid programs. That is what the place of service they want on that 1500 claim to show it's a telehealth service and not an in-person service. And then for the hospital, Missouri particularly is wanting 2 line items on that hospital UBO4. The first would have the revenue code for the site where that clinic is located. We would assume the 510 for an outpatient hospital, department, or clinic. The Q code, the GT modifier, and then the charge. And then they would want a second line item showing, again, the revenue code and the facility billed charges. So you may want to jot that down as an item that you'll want to follow up with your state plan to make sure that you have any hospital UB forms submitted correctly. Now, regarding the distance site, this is the other component of that telehealth service. Again, audio, visual, or perhaps phone only. And the distance site is really the professional service. That patient is housed somewhere, either at a healthcare entity or a home. They are connecting remotely with a provider that's rendering that professional service. And telehealth really is that replacement, as we've said, for an in-person visit. So they're coming in for an evaluation medical visit. They may be having a preventive service like the well checks. Those are also available to be done over telehealth. One thing I did not mention yesterday, Kate, this may be something we can put out later just as a clarification or will be on the recording, is that some of the state plans for their well child checks, just FYI, have an age range where they will accept an audio-visual telehealth versus in-person. And most of them have said up to 24 months they still need to be seen in person. And then anywhere over 24 months that they would allow them to have a remote. But that may be something that will need to be noted so that you're aware that patient would still need to come in for their EPSTT or well child checks. Just an extra note. But the distance side is your provider. Medicaid gets into more detail of who is recognized as a distance side provider. And that either is listed as an individual provider like a physician or a non-physician practitioner, or they will list sites where those providers that are within that site can provide those services. And those include, of course, our RHCs and our FQHCs and a number of our other behavioral health or school-based clinic sites of service. You'll see a list of the most common general categories of providers or healthcare entities that are approved to do distance site services. On the behavioral health side, I would recommend, and we've included some of those references on the tool that Kate referred to as well as to this presentation. There are a much more involved set of guidance on the behavioral health side as to who can be included, going into some of those licensed or non-licensed providers like marriage and family therapists and things like that, where those providers are also eligible. Medicaid does make it very clear that those providers have to be licensed in the state, not just certified, and they also must be enrolled in the state Medicaid program. So that's something that you also want to keep in mind if you are bringing on providers or staffing temporarily to assist during the emergency. Medicare has an emergency hotline set up to fast forward any enrollment needs, to temporarily set up those providers if needed, and state Medicaid most likely will also have a fast-tracked enrollment process. But those are some of the criteria that Medicaid has in place. You want to keep that in mind if you're bringing on additional staff or new staff. They also have to be acting under their scope of practice. That's just a standard for any medical or behavioral health service that's rendered. That provider does need to have that expertise under scope of practice, or the service line under scope of practice. So that also has been a bit blurred now with the emergency, and we have had some calls where, let's say, social workers are really fielding medical based questions. You want to make sure that those providers on the other end of the line are actually acting under their scope of practice based on what the payers will require. Now, the state Medicaid plan really compared to Medicare. Now, Medicare has a list, literally, of all CPT codes that are eligible to be rendered under telehealth, audio, visual, or phone only. They've also gone to the extra step of listing those items that may only be phone only or are acceptable as phone only versus audio, visual, or a combination of both. State Medicaid sometimes will lump into categories of services, but there are some of the state Medicaid plans, and we've tried to provide you with some of those links, especially for behavioral health, where they go into great lengths of listing what codes are appropriate under the state plan. Excuse me. So we would refer you back to some of those resources to make sure that everyone is aware of what services can be rendered remotely. It is not every CPT or HCPCS code that a provider would ever want to provide. There are services that are still required to be in person, so you want to make sure that you've taken note of that. But some of the categories that are always included are any of your medical, like your E&M services, your routine annual physical, some of your wellness services. Those are covered under telehealth. A lot of your behavioral and mental health services, to include some of your substance abuse services, are also now considered under telehealth, while there are, under some of the state Medicaid plans, some criteria, particularly for substance abuse or MAT services, that may be rendered, that you do want to make sure you are noting and sharing with your providers to make sure that you are meeting those guidelines. Just as an example, for some of the extended providers that are listed under some of the state plans that we noted for this webinar are your psychologists, of course, your licensed clinical psychologists, LPCs, your LACs, some of your marriage and family therapists, and then, of course, your social workers, to include an LMSW. There are often case management requirements as well that are listed out in the guidelines, and that would be specific to behavioral health versus like a chronic care management that has a separate set of codes that are for remote services or non-face-to-face services that are still in play. And then therapeutic services like physical therapy, occupational therapy, and speech, as well as services that might be rendered in a school clinic setting. Those are usually the categories that most of our state plans have as eligible for telehealth. So walking through some of the billing requirements or some of the claim detail that are provided by the state plans, for Arkansas, for your telehealth services, audio-visual, you would be billing under a 1500 claim form or a UB04, depending on your site of service. That provider must be an eligible, enrolled, licensed Medicaid professional, and that service would be also eligible for telehealth services. They would like to see the T1015 for medical or behavioral service codes, and place of service 02 or revenue code 521, depending on which claim form is being submitted for that site of service. They want to see modifier GT for medical services, and for behavioral health services, they have a UT modifier and a GT modifier. Both are required for behavioral health services. And they have indicated that our telehealth services will be paid under either the rural health clinic encounter rate or fee schedule, whichever is applicable. For Louisiana, they are also on 1500 claim form. Pretty much across the board, I did not see guidance for UB04, particularly for these distance site professional services, as well as RHC. Again, must be an eligible service that is approved under the Louisiana Medicaid guidelines. You would assign the actual CPT or HCPCS code that describes or is supported by the documentation of that service. Place of service 02, again, you're going to be seeing that consistently for all of the state Medicaid plans. 1500 claim form 02, place of service. Louisiana would like modifier 95, and then the service will be paid either under the applicable RHC encounter rate or the fee schedule. That is a rate that's applicable for that site of service. And finally, Mississippi, they also want to see a 1500 claim form with the CPT or HCPCS code describing the service that's rendered. Place of service to GT modifier, and again, they also will pay under the encounter rate for RHC or the fee schedule allowance for the applicable site of service. You'll notice that this is really interesting that state Medicaid really picked up and is paying the encounter rate for your rural health clinic distance site telehealth professional service. On the Medicare side, as you're most likely all aware now, they calculated a fee schedule allowance for that distance site service instead of the rate. And I know there is legislation in place that's being looked at and hopefully will be passed soon. Medicare is actively looking at that again from what we are aware of, and have heard from some of our national industry leaders on the rural health clinic side that it is being challenged to Medicare that they reverse that guideline and move that to an encounter rate rule versus fee schedule payment. So we're kind of waiting to hear. That was another thing that Medicaid was a little bit ahead of the curve. They had always allowed that as part of an encounter payment versus fee schedule. So you will note that difference when you are receiving your remits. For a phone-only telehealth service, and again, this is a replacement for that in-person visit, but the patient does not have access to audio-visual. So you are completing the telehealth work, but you have to code those services out a little bit differently. For Arkansas Medicaid, they will just want the service code for the service that was rendered, place of service 02, the modifier GT. For Louisiana, they also want just the service code that's supported, place of service 02, but 95. So this really will mirror back to what these payers want for the audiovisual. They've really mapped those same guidances over to a phone only. Now the only exception to that is Mississippi, where they wanted the 99441 through 443 for any phone services. Place of service 02 and modifier GT. So that is one of the exceptions to the rule. And we had a few states in our last webinar also that wanted it to fall back to the actual phone-only code instead of the E&M or behavioral health service, for example, code. Now our next category is our virtual check-ins. Just as a reminder, this is the code set that really has some caveats around it. And there are some state Medicaid plans that do or do not recognize service coding for these virtual e-checks, or they may want different sets of codes for these particular services. G2012 is really a CMS established code, but over the last several weeks we've seen most of the state Medicaid plans who have updated their guidelines, and I did see that within the 3 states that we have represented for the webinar today, is that they also have language in their manuals and some updated transmittals that they would also start recognizing that G2012, which would be that phone call initiated by the patient, basically a triage by the provider to determine next steps. Usually a 5 to 10 minute call. This is one of those services that cannot be related to a prior E&M service rendered within the prior 7 days. And if it results in a in-person visit within the next 24 hours after the call, then the phone call itself is not billed separately. It is considered part of or integral to those other visits that were already billed or would be billed and not paid separately. This is, again, that service that can't be billed more than once per 7 days. And Medicare has not been clear, nor is there clear guidance from state Medicaid about what if the patient calls about new problems or calls multiple times during the week. It really goes back to once a week for those types of triage calls are once every 7 days. So those are the guidance that you want to be clear on going forward. Now, G2010 is another form of e-check, but this is again a store and forward type of e-check where the patient may send in a photo maybe of a skin lesion or something that they need to have the provider look at, and then the patient may be called back to provide next steps. Some of the Medicaid plans have not issued acceptance for that G2010. Again, they want to keep that two-way real-time communication between the patient and the provider. So you will have some state Medicaid plans that will not accept that G2010. So for Arkansas and Mississippi, we saw clear instructions. Arkansas recognizes that G2012, or they will recognize the T1015. Either or is acceptable if that was an e-check billed on the 1500 under place of service 02, or the appropriate revenue code if you're billing on the claim form for RHC, a UB04 with revenue code like 521 for an office, and modifiers U7 and GT would be appended to that T1015. In Mississippi, they also, and I have a typo there, my apologies, we did not catch that. On Mississippi, it's reporting 2012 as well, place of service 02 on that 1500 claim form. So again, that is G2012, not 2015. Both of these services, or all of these phone services that are e-checks or virtual, are paid under the fee schedule allowance. We did not see, going back to this slide, we did not see any guidance for Louisiana on the virtual checks. Everything seems to fall back to, if it's phone, then you just go back to the service that was rendered. We will continue to look in the Louisiana guidelines to see if anything has come in for that G2012, and if so, we'll provide that to Kate to distribute to the membership. There is also the portal e-visits, and again, that's when the organization may have an electronic or internet communication portal set up, where it's usually just an email or instant message type of system back and forth between the patient and the provider. This also has some caveats that this is time spent over 7 days. Usually we have a new or established patient scenario, and you'll notice that when we distribute the tool, you want to pay close attention to the e-check and the e-visit sections of those tools that we'll be sharing with the organizations, because there are state Medicaid plans that have been clear that although for telehealth, that window has been open for new and established, where new previously was not acceptable for telehealth. On these digital or remote, these non-face-to-face type services with the patient, that is only for established patients. So that's one thing you'll want to share with your providers, that some of these state Medicaid plans still want that provider to have a relationship with that patient before they are calling in with questions. So we have indicated those states where that is a caveat of providing some of these remote services or virtual services. They need to spend at least 5 minutes or more within that 7 days. So that's something that falls back to our documentation about where we want that start and stop time. Even if it's a very brief communication with that patient, that needs to be documented in the record, because you may not bill these services unless you have at least 5 minutes, and that goes for that e-check as well. There is a time increment on that. And then the codes that are in place and will or will not be recognized by your state plans are either 99421 through 99423. And you can see that each CPT code does have a time allotment, 5 to 10 minutes, 11 to 20 minutes, or 21 minutes and over. And then there are some G codes that may be recognized by your state Medicaid plan that are set up for non-physician or non-physician practitioner staff. Usually the rule of thumb is when you're differentiating which phone call or which digital service code I need to report, you determine that by, does this provider usually bill E&M services like the new or established patient visit codes? If those providers do not bill those medical evaluation and management services, and they may be working more on the behavioral health side where those codes do not include medical E&M, then they would fall to the other set of codes, which are the G2061 through G2063. Just as a note, you may have another set of codes also for your non-Medicaid, non-Medicare payers. That is, again, another set of CPT codes for your commercial and your MCO plans. So this is what has made billing for these services very complicated during this emergency, just because of the changes in guidance. Now, as a reminder, consents are required for any of these virtual or remote services, telehealth services, and Medicaid particularly has also mirrored Medicare's requirements that consents are obtained. The consents can be obtained at the time of that remote or telehealth service. So I know that some practices have that as one of the chores for the ancillary staff or the nursing staff when they're on the line or the phone prior to the provider joining the telehealth visit or the phone call to obtain that service, such as getting that bit of history, obtaining those vital sign bits of information from the patient, as well as making sure that consent is obtained. That also discusses with the patient any of the guidance about the fact that this is a remote or virtual type of communication, making sure that that equipment is approved for this type, that they're very well aware that there may or may not be issues with that type of information, making sure that all of that is included in that discussion with the patient if you're obtaining a verbal consent at the time the service is rendered. Both Medicaid and Medicare require that that consent be obtained and documented before that service is billed, but can be obtained at the time of service and is not required to be obtained prior to the service, which is our usual process for consents. It can be verbal or written. That really is up to the practice. And in this scenario, we have seen that majorly it's a verbal consent that is being obtained during that remote communication. Now, really across the board, but really for rural health clinic providers, there's always that concern of supervision over our ancillary staff, and Medicare as well as the state plans have also kind of opened that up, making sure that there's just general supervision of that ancillary staff at that time of the visit. Wanted also just to share some cost-sharing information for you, since Medicaid and Medicare are a bit different in that respect as far as do modifiers need to go on the claim form. We did not see any indication from any of the state plans that there's a particular modifier that they want on billed services to indicate that cost-sharing or that coinsurance is waived. This appears to be more of a state-driven recommendation or application to the state to let them know that you will be waiving. In some circumstances, it is just being done on the back end by the payer, but most of the Medicaid and MCO plans do have some cost-sharing procedures in place as part of this emergency. Some of them are related directly to COVID-related services, and some of that will be driven by your diagnosis code under the guidance of Medicaid as to how they will determine the waiving of that cost-sharing. States that wish to waive co-payments that must still submit an SPA. If that exemption would apply to everyone who's received a particular service or item, and then outside of that, there's a Section 1115 authority, really universally for state Medicaid programs, for temporarily suspending co-payments only for individuals needing treatment for COVID. So really there are several options under the Medicaid program. From a billing perspective, there is not a specific waiver modifier that they require. You want to make sure that you understand what the programs are for your individual states, make sure that those applications have been submitted if they are required, or understand the process that the Medicaid plans will have in place to recognize that Section 1115 authority, which may be done on the back end and may be tied to your diagnostic information that is coming through on the claim form. It may also be tied to laboratory testing services as well, since there are specific lab codes, of course, that have been identified for COVID. We also have the question as to whether or not a provider can provide services, particularly these remote services, when they are at home, because we do have a number of providers that are either being quarantined or to reduce exposure or keeping staff within the clinics at a low level, and so some of those providers are working from home now, and that is acceptable. State Medicaid really has language that says they require all providers to practice within their scope of practice. Some states have enacted legislation that requires providers using telemedicine across state lines to have a valid state license in the state where the patient is located. That has also been a caveat that has really been discussed from the legal side, from many of the legal firms who have had information out regarding the COVID and this issue where the providers may be in one state and their patients are in another state and they're connecting remotely. It is always to the benefit of the organization and a recommendation that you always take that extra step to contact the state's medical board or licensing board to make sure whether or not they will want some type of licensure or temporary licensure for providing those remote services. So that's some extra steps you may need to go through to make sure that your services will be covered. And then the state plan also allows licensed providers to render telemedicine e-visits or digital visits from home. Basically, they are looking at that as you are rendering that from home instead of being in person in your usual place of service, like your clinic. And so your services would be billed as if they were in the clinic itself. So if that's an RHC provider who is working from home, you would submit those claims just as if that patient was inside the four walls of the RHC for the time of this emergency. Some brief comments on the documentation, and then we'll open it up to questions. We have had some documentation questions over the time. We've answered some items from Kate and her team, so we wanted to make sure that we populated this as well. You want to make sure that your documentation processes are the same as if that patient was inside the clinic. The documentation needs to be clear at reflecting the service that was rendered, and documentation needs to be retained by both the distance site where that professional staff is rendering services, as well as the originating site. If that patient has physically come into a site of service, that would also be in their records at that place of service because you are submitting service charges for that. So the clinic or the hospital would need to note that the patient was housed in the particular site of service, what service was rendered, et cetera, just to support that originating site fee. There should be a format, a template, or some type of remote telehealth or e-visit, et cetera, documentation template that's going to be compatible with your current practice management system or your electronic medical record system. You want to make sure that you have some mechanism in which to document that verbal or written consent and acknowledgement discussion with the patient. And then it is really recommended that during this public health emergency, with the increase in use of telemedicine and other virtual communication, that documentation be completed within 48 hours. It is really a timely issue. You are remote, you're not face-to-face, everything is very subjective, it's obtained over that phone call. You just want to make sure that that documentation is extremely timely. Other documentation criteria includes the type of service. You want to make very sure that either by headers or an opening statement that provider has clearly noted that it is a telehealth audio-visual or telehealth phone, it is an e-check, it's a digital visit, so that will map appropriately over to your billed charges as well as just to support the service. The location of the patient is important, particularly now that home has been opened up as the originating site, so that's important to put the location of the patient as well as where is the rendering provider. The name and credentials or roles of any ancillary staff that's part of that visit, just as you would where they're documenting in the record for an in-person visit, their documentation should also be present in the remote chart note. Orders, making sure that you've identified the medical necessity for these remote services, tying back to that presenting problem, your final impression, your ICD-10 codes that will be mapped to that. And then the rendering provider, of course, again, just a reminder to the staff, they need to document just as if that patient was in front of them and support the service that they're rendering. PHI information, of course, will still be important for these pieces of documentation, so including that patient name, date of birth, any identifier like medical record numbers, et cetera. Referring physician or provider if applicable, the rendering provider, name, credentials, orders, start and stop time, particularly for the phone-only services. A lot of your payers are falling back to a time-based CPT code like the 99441 through 443, without any time, you won't be able to support the code that you have selected. The type of evaluation, whether it's a new or established, if it's a routine annual physical, a well child check, what type of service, behavioral health, was this an initial assessment, was this a therapy visit, the consent, that provider's assessment, if that's applicable to that service, the decision making, and of course our final impression for that patient. Your behavioral health also will have all of those same criteria. If there's an initial psychiatric evaluation, all of those criteria need to be met. I know for some Medicare questions we've had on some of their preventive services, we know that the physical examination and any vital signs will be a subjective obtaining of information, and most payers have allowed that the patient can be asked that information, and that is the information that will suffice for those vital signs. We do know that there are some telemedicine applications out there where the patient can, for example, put their thumb on the sensor and that can read several things to include O2 sats. So it just depends on the software that's used. But understandably, all of the physical exam and vitals, really the entire visit is all subjective. And with that, I'll turn this back over to Kate to see if we have any questions.
Thanks, Marla. Yeah, so just a reminder, *2 to unmute your line, or you can use that chat box to put your questions in. Again, this information will be sent out to you as a resource and will be posted on our website. The Medicare information is also on our website, and then those resource documents will be sent out as well. Those will be great for you to, you can even print that out, use it as a cheat sheet. They're in an Excel format, so you can manipulate if things change, as they probably will going forward, to keep that resource updated for you as well. While we're waiting to see if there's any questions, I'm going to have Cinebelle pull up some post-polling. If everybody could take a quick second to pull up the post-polling. Marla, I know we had a question from the group yesterday talking about whether or not they should hold on their claims, and I know you talked through that because there's been some kind of confusion and sites looking for guidance on that piece as well.
And that is a good question, and it is really a universal concern with all of our healthcare entities, whether a hospital or clinic, because of the volumes of claims that are being held. I know on the Medicare side, there has been some back and forth, particularly on the RHC side, about what service codes can be used. They have that phased billing approach for dates of service, or filing prior to June 30 and then filing July 1st and after. And in to a great degree, the Medicare guidelines for that phased kind of claims processing is because they have not yet updated their system and won't have their edits completely updated until July 1st. We've seen that issue with other services as well, not just RHC, but just guidance for claims that you may need to hold because Medicare may continue to change their guidance on a particular code, or the guidelines behind who can bill. For example, the originating site that is a possibility now for the hospital provider-based clinics. There is still some gray area out there, as well as guidance, and some of the payers have really had some hiccups on either sending denials or not processing the claim. The reimbursement is not coming through correctly. So our recommendation, particularly on the RHC side where we have this phased claims processing going on, that if your organization is in a financial position where you are able to hold claims, particularly on the RHC side, until July 1st, or just in general, if you're seeing that Medicare still or other payers do not have their systems updated yet and you're continuing to kind of circle around with these claims over and over and you're eating away at your FTE time, hang on to those claims and wait for finalized instruction if you can from the specific payer. And then submit once you know that they have their systems updated. I know on the RHC side that has been recommended because once you drop your claims as of July 1st, they'll process under the new edits. And you won't have this back and forth with not only the reimbursement you receive, but the potential to have to pay back some of that money because they're going to start out paying you one way under the rate and then back that up to the allowance that they've set for this particular telehealth service. So if you're able to hold those claims, I think to save on some of the headaches that the business office is currently going through,